extremely honored to be asked to present tonight and tomorrow for two different aspects of occupational medicine. I want to thank the organizers for asking me to provide a couple of lectures, and I look very much forward to meeting you in person someday. I would love to come and visit you as soon as we can, given the circumstances. So my talk tonight is after COVID-19 pandemic, what will be the direction of occupational medicine physician? I think this is a very intriguing question, and I'll do my best to try to answer that question. And I have left a little bit of time at the end, just so this could be a discussion as well and questions, because I'm sure everyone has an idea of what it might be. And obviously, it's dependent on where you live and how you work, as well as the global situation as it relates to COVID-19. I know we're getting quite tired of this pandemic, and hopefully we'll be in a different state in a not too distant future. But I'll discuss that. Obviously, we all well know that this pandemic, as have others, has been devastating. And I will point out that it's not been exactly as devastating as in all countries equally, as you may be aware. But I'll show some interesting information such as this. We'll talk about, Dr. Kane was mentioning about deaths and dialysis and so on. And I think this is a very interesting methodology they used in the Economist this year to estimate that they estimated that 5 million deaths, which we've heard about recently, is a terrible threshold being reached, was actually higher than that. And again, some countries were more affected at different times than others. And this is a list of the top 5. And what this shows is the excess deaths by country. And again, last updated as of November 8th of this year. And the color scheme, as you can see, is related to the deviation from expected deaths, meaning that the darker the color, the higher the number of above the expected deaths. So the excess, really, due to COVID-19. And just for example, Bulgaria is given at the top, and it's given by the months from January 20th, when this all basically started for COVID-19. And you can see during certain times of the year, they had higher, up to 200, over 200% increase, or twice the number of expected deaths at any particular time in year, presumably related to COVID-19. Some countries were hit for longer and more seriously for excess deaths percentage from their usual and baseline. And for instance, Peru down there, and then Ecuador. The next slide is another set of countries, and I wanted to point out Thailand, since we're, this is a wonderful conference, and I wanted to point out some local information about that. And you see that, at least with according to this information, that Thailand has had a relatively less excess deaths than others, although it's not been spared either. Australia is in the same kind of category, as you can tell, in New Zealand. So I think this is interesting information that please consider that there's excess deaths, and many of those excess deaths are from occupations. As Dr. Kang pointed out, is a very an occupational disease as well as a non-occupational disease. So when we look at a COVID-19 pandemic timeline, I just picked before, which is probably late 2019 was before really all this started, because we're now in 2021, of course, almost 22. And after is the question. So when will after come? So when we think about what the occupational physician will be, how changed or the practice may be altered, but when will that be and what will it look like? So that's the first step. So as I was thinking about putting this lecture together, um, and I do thank the organizers for selecting this one. I like this saying, it is difficult to make predictions, especially about the future. And I feel that way I think we all feel this way. This was by Yogi Berra. And if you might know of United States baseball, he was a legendary baseball player and a philosopher, actually. Well, actually got a doctorate degree. He played catcher for the New York Yankees for many years, and then went on later to actually coach the New York Yankees to some championships. But he made comments like this that made you stop and think for a minute. Did he really say that? But I think this is really a true way to look at what I'm talking about. So predicting when after will be, because the first part of the question was after COVID-19. So this is one way I approached it. I like doing predicting and forecasting, and I do that kind of work. So the world's population, this is just my calculations how to do this. The world's population is approximately 8 billion people now. Let's assume that 100% vaccination against COVID-19 eliminates the disease. These are all assumptions, and you always make assumptions, obviously, for making predictions. Let's assume that 50% get the two-dose vaccine, such as Moderna, Pfizer, and 50% gets the one-dose type vaccine from, say, Johnson & Johnson or AstraZeneca. So the after, quote-unquote, date might be predicted to be when 12 billion COVID vaccine doses are administered worldwide. So the question then, when will that be? So this is a quiz, and I'll just let you think about this and select what you think of these 5 time frames might be the time we can predict as best we can when COVID vaccine can be administered worldwide for 12 billion doses. So would it be before April of this year, or April to May timeframe, June to July, August, September, or after October? So let you think about that, let you select which one you think. Then I will compare it to a team of super forecasters at a company called Good Judgment in the UK. This is was reported in The Economist, The World Ahead in 2022. And this company, as they describe it, is one that all they do is make predictions. And they predict for purposes for governments, for businesses, and so on, as I understand it. And this was a team of super forecasters, whatever that means. But they come up with when that 12 billion dose could be reached. And as you'll see, it's actually, it looks like they say it's going to be June to July when we'll be giving out 12 billion doses. If that could be true, but you see there's a scatter. I mean, even 20%, 1 in 5 thought it'd be after October. So big uncertainty there, but there seems to be some centering around, about half thinking about it's going to be this coming summer. Another question that was asked of these super forecasters for this study was, when will a SARS-CoV-2 variant, meaning COVID-19, other than the Delta variant, represent more than 70% of the total COVID-19 cases in the United States? This was the question they asked this group. And of course, we have Omicron coming in very quickly. This is before they asked this question beforehand. But again, they gave some time frames, and they were thinking, this group, more than half, thought that it would change to 70% more variants other than Delta after September of this year, next year, I'm sorry, 2022. So again, there's a lot of uncertainty when this is all going to change over. And I was just illustrating that. But another view was in that same magazine, which I think is a very interesting one when we start to understand what the future may look like for all of us as well as in our profession. And I quote, "COVID is not done yet, but by 2023, it will no longer be a life-threatening disease for most people in a developed world. It will still pose a deadly danger to billions in the poor world, but this same is sadly true for many other conditions. COVID will be well on the way to becoming just another disease." So I would offer to you for your consideration that it's not going to be an after COVID-19. It will be a new environment, a new world in which we live, where COVID will be just another disease, perhaps like influenza or other diseases that can be deadly, and we try to control. But since we may agree, yeah, we may agree that pandemics do not die; they fade away. But can they lead to progress in occupational medicine? I think that's more the question. And we look back in history, and we all will recall in 1854 the cholera epidemic in London, where John Snow, who was an epidemiologist, as it turns out, figured out that the cholera was being spread from certain wells in London. And so by using very basic epidemiologic technique. And so he went around and took the handles off those pumps, and the cholera epidemic went away. Because that's before they even understood anything about germ theory, what the cause really could be. In fact, there was the cause he thought was actually touching something about the handles. So I had the wrong idea, but got the right answer. Of course, the Great Influenza of 1918 taught us a lot about public health controls, distancing, face mask, investigating what the cause could have been. But it took about a few years to understand how that all originated and how it was still trying to understand exactly. But there's been a lot of research. It stimulated research into epidemics. At COVID-19, I put a question mark. I think we will see that progress in our profession, and I will show that later on in this talk. So that turns to the question really at hand, and that's how will COVID-19 pandemic affect occupational medicine physician? Now, these are my speculations, and from my over 30 years of occupational medicine practice, and former president of ACOEM and so on. So I would like to share my thoughts, but I would welcome any of yours. So this is sort of my list. And again, I think this list can be expanded and should be expanded. But this is sort of top of my thinking. And there's some other people I talked to about this topic because I thought it was a very interesting one, thought-provoking. So one of the people I talked with was Warner Hudson, who was also a former president of ACOEM. And he said that occupational medicine is public health for the workplace. And I couldn't agree with him more. But I think it's become much more recognized in the general public and in government circles and our colleagues that this is really true. And when we study to become occupational medicine physicians, public health is obviously a big part of it. And now I think our practices are going to be using it more and more, and it's being recognized as a very important source of information for organizations and governments. And so the value of occupational medicine to organizations and governments has certainly been heightened. I was listening to lectures I was actually in Boston last week at the Northeast Occupational Environmental medicine component of ACOEM for their annual meeting. And there's a big discussion about this among the occupational physicians there, that a lot of their roles have changed to organization health security, which I think is a very interesting concept, that we're being asked to help secure the health of the organizations. They see their value in that, our expertise in that area. And we've talked about security, biosecurity, and all this, but organizational health security is certainly a public health concept, certainly one of prevention when we're looking at groups of people rather than single individuals. And we certainly have that skill set. And I know from my clinical practice, and I practice every day at a clinic, occupational medicine clinic at a pharmaceutical company, and I see this happening to me over and over again. That is a role in what's called the triple play strategy. Kind of a baseball analogy again, but I think it fits. We're talking about vaccines, testing, and therapeutics. I think we're being brought into these three areas. I know I am. But it could be giving the COVID-19 vaccines on site, for instance, to workers, testing workers for PCR or rapid tests, find out if they could be at the work site, it's safe and not to infect others. And ideas of delivering therapeutics to those who may have been exposed or are ill and they or could be ill and need to have, say, for instance, monoclonal antibodies, or if that's going to be a proven therapeutic. I think there's some challenges. Although all this recognition is very nice, and I think it's increasing our importance to the society as a whole, and certainly to our colleagues who are, say, are not in our field, who really don't really understand what we do that well. But we have challenges. But this is challenges also for our entire, not just occupational medicine. Some are, some good or bad to them. For instance, I think here, at least in the United States, and I'm sure in many other countries, telemedicine has become here to stay. It's got challenges, with the technologies, how the physicians use it. There's some legal issues around, where you're licensed to practice. But I think we're seeing a lot of telemedicine now. The psychiatrists are talking about mental health for our workers or even their families. Telemedicine is now the standard here. No one seems to be doing any psychiatric care face-to-face anymore. Part of initially the reason was to prevent, spreading COVID to the staff, clinics, obviously. I'm doing telemedicine. There are challenges. How do you with the technology, documentation, and all that? How do you do a musculoskeletal examination by telemedicine? Well, I think if you look at the Mayo Clinic, they have a very nice video of how to do a complete musculoskeletal exam by asking the person how to do their own movements, and you can see that on telemedicine. I think teledermatology has been a big push forward, and those of us who work where skin diseases can occur at the work site, I'm seeing those, and the question comes up: is this work related or not, or what is the diagnosis? A lot of this can be handled with taking a photograph and sending it to the dermatologist, which I think is a really, really, really nice way to try to get some extra help. But it's also been a rapid rise in medical, not only medical information, we all know that we've had lots and lots of studies coming out. Some of the studies getting out onto the media before it's peer reviewed or even published. We're having to try to understand that information and try how to apply that to our work sites, to our workers, and even our families. There's also a lot of misinformation, which we also have to understand what it is and then how to react to it and try to convince otherwise. I think we've not been put in that role so much as now. When it comes to anti-vaccine, for instance, it's been a real problem. Not just in the United States, but I'm talking globally. Germany comes to mind recently. The last two I want to talk about a little bit more in depth, just I think because it's really quite appropriate. And I think this is going to be discussed during Dr. Go and others. So I don't want to, I'm just going to not talk too much about it, but other than to say, we're finding, I think COVID is a costly new occupational illness. It's the first occupational disease that actually was for in the last 10 years for sure. And we're learning lots about it, but it's also partly acute and also chronic. So, and also I want to talk about a new regulations. Various countries will, I'm sure, have this, but I'm going to talk about the OSHA COVID-19 Emergency Temporary Standard because it is very unique, kind of first of its kind, actually, for the United States. And it may become a pattern, actually. We'll see. So COVID as an occupational illness, and certainly, the healthcare and staff has been hit by this. I know the hospital I'm at a Johns Hopkins University Hospital, where I'm on staff. It's been a big problem. And to the point even that a lot of people have been burned out in terms of their psychological, they just can't take it anymore and have been so losing staff from that purpose, they're resigning, but also getting the disease. I know of physicians who have been intubated at the hospital who were on staff of the hospital, and they themselves came down with COVID pneumonitis. Now, this is information I got last week from the conference I just mentioned. Dr. Craig Ross, who is medical director at Liberty Insurance Company, which is a workers' compensation insurance company. And he was quoting some statistics from a study from 2022, the whole year, for 35 states in the District of Columbia to show impacts to the, these are claims that were accepted as work-related from COVID-19. So the losses, not just his company, but others combined for those 35 states were at $260 million last year. That came from 45,000 claims of work-related COVID. The average cost was $6,000 per case. And not unexpected was that 75% of the claims were from healthcare and from the first responders, meaning the ambulance drivers and the paramedics that went out, to get these people to bring to the hospital. About 1% of the claims were over $100,000, which accounted for 60% of the total losses of $260 million. And all those cases were because they were in intensive care unit. And then the other item was a loss of workers, people just leaving the workforce because they just don't want to be in the environment anymore, or frustrated, or they themselves ended up with a long COVID. And I know that's going to be another discussion and topic for this conference. So I think that just illustrating this is an issue. And I know there's going to be more discussion about occupational groups, but here's my quick take on it, is that the first work group identified, as I think we all know, is the animal wholesale workers in Wuhan, China. But soon thereafter, occupational groups that were affected included healthcare workers, staff in tourism, retail, and hospitality, which have been decimated. I did some consulting work for Hyatt Hotels International. We're trying to help with their staff to feel comfortable, and taken care of, and not get infected themselves, as well as convincing people to come back to the hotels. Meat packers, transport and security workers, construction site workers, and others. And I give the two couple of references here. I think Dr. Coase has a nice editorial on this in the Occupational Medicine recently too. So I would refer to those articles. But there was one article that struck me because of the timing and also because of the way they had set up their, and I used to work for a German company, so I kind of understand their systems. And I love statistics. So this one gave me some standardized incidence ratios and confidence intervals by looking at how the risk differs between occupational and employment. And this is in Germany. And this was from diagnoses made in January to May of 2020. So really before the vaccinations arose, particularly, since it's fairly kind of, I think, a good view of the kind of the pre-vaccination, even pre-treatment, risk as seen in I think, a very structured system. And I give a reference here. And I'm just showing part of the table 2, which had it only for the hospital diagnoses, also had the outpatient diagnoses list. But I thought this was illustrative. They actually put the groups in, they made their occupations in 3 risk groups, high, very high, and what they call OD 3101, which is by definition an occupational case if these individuals work in health service, lab, welfare work, a lab where they are exposed to COVID or can be, or a similar extent in other activities. So it's kind of the miscellaneous, but at that same level of risk. Those are by definition occupational diseases. And you can see under the SIR column how how the risk went up from 1.09, which was not really sufficient, statistically significant, from very high to the OD 3001, which was now 1.8, almost twice the risk compared to the high. Now, looking at subgroups, these were employees of subgroups. I think it's interesting to see not only what the risk that they varied based on the occupational work that the individual did, but also as an interesting list of again, makes us think about the people we're seeing in our clinics and asking what they do, because they could be at higher risk than we might think. For instance, employees in postal services and logistics sectors at 1.53, security services and law enforcement 1.75. Employees in patient contact in hospitals and medical practices, which we're all well aware of, at 1.175 again. All these statistically significantly increased. But higher than that is employees in the sector of providing and caring for the elderly, who, for instance, could be nurses and others, are caretakers in elderly homes. And also highest, and I thought this was interesting, was employees in temporary agency work in production and logistics sectors. So these individuals who would just go from job to job, get, maybe the highest risk we'll see. Here is 2.3, and it was the highest in this study. So I think this shows that we have to think broadly and think through the commonality of what the risk factors could be for this. And, for instance, crowding, face-to-face contact, that kind of thing. So this is I thought it was an excellent study just to get an idea of how us as occupational medicine physicians, probably almost most people we can see or can be in these groups, and when we have to be aware that they're risk. So when we talk about COVID as a new occupational illness, for the future, again, this is from Dr. Ross, in this country, and I think others, they have something called presumption laws, meaning that if the person gets a disease, it's presumed to be an occupational illness until proven otherwise. So the burden of proof is indicating that it isn't associated. So the presumption laws for COVID-19, there's been a lot of controversy here in the United States about, is COVID, when is it an occupational illness, when is it a personal illness? Because clearly the person could get this from their spouse at home or anywhere, other places. So how do we know? Well, these presumption laws, in fact, I think there's been one proposed in California that if it's in a healthcare worker, it is presumed to be due to their work and therefore covered under workers' compensation. That's what I'm talking about. I think the prediction is that's going to expand, which will change it, meaning as that happens, we will be seeing more individuals who, no matter what we decide in terms of causation, has already been pretty much decided from a legislative perspective. So we'll be taking care of them as a work-related illness. Claims from work at home incidents will increase. I know where I work, that initially everybody who was not considered essential staff was asked to work from home by telemedicine, telephone or by internet. And about 75% of individuals fell in that category. But then things started happening at home, including ergonomic issues, trying to work on a computer. So a lot of people were working, putting their laptop on the kitchen table, not the best of ergonomics. They might have an accident, trip and fall, which can become compensable under workers' compensation, that kind of thing. And I think that's going to increase. Progression of immunization claims, meaning because we're now, and I'll show this in a minute, mandating vaccinations. What happens when the person has a reaction to an immunization? That becomes compensable. Probably in the future, as the standards of diagnostic criteria for standard for diagnosis criteria and treatment guidelines for so-called long COVID cases will start finding more cases, meaning we'll be more involved with these. And I've already seen probably a few of these cases already, both at work and in consulting for their disability. To go along with that, it's anticipated that there'll be an emergence of long COVID rehabilitation programs. I know the Mayo Clinic has already talked about this, and many other locations, and probably maybe where you work as well. These rehabilitation programs are becoming beginning to start, and I think there's an occupational physician will be obviously involved with that. What's not so clear is as treatment options for COVID-19 develop, with the pill that you can take, as soon as you become ill, which may happen pretty soon, will claim severity go up or down? It's not clear at all. Just checking the time here. Okay. So the other aspect of occupational medicine physician will be dealing with, at least here in the United States, and maybe in other parts of the world as well, is this COVID continues, which I mentioned before, the after is not going to be that soon, and it may not ever be after. It's just different. So the OSHA and emergency, what's called emergency temporary standard, the background is on September 6th of this year, President Biden announced a 6-part path out of the pandemic plan. Employees are exposed to grave, imminent danger from a hazard, is what was written in the when they announced it. In the United States, we have something under our OSHA Act itself called the General Duty Clause, which is just very vague, and it says an employer has to give a safe and healthy workplace to the workers. And President Biden said, no, that's inadequate, that the general duty clause will not protect workers. So the aim was to use OSHA to increase the percentage of the United States workforce that is vaccinated in businesses. So to apply to private businesses with over 100 employees, which is about 85 million people, OSHA estimated they would save 6,500 deaths, and over 250,000 hospitalizations would be prevented by enacting this emergency temporary standard. And although it's called temporary, it is a proposed rule, but after 6 months, it will become permanent. But as you may know, that we have a lot of legal challenges here when these kind of rules come out, particularly like this one, and the courts have disagreed. They've stopped it so far from being implemented, because it was actually parts of it were going to be implemented already in November, and employers are being impacted by January 6th, but all that's on hold right now. Some of the rules are interesting. It's actually 3 different regulations. There's a healthcare emergency temporary standard, which means mandated vaccination for all workers in healthcare, meaning hospitals, clinics, and so on, if they accept what we call Medicare and Medicaid, which are the government health insurance programs. All federal employees and their contractors of the federal employees and federal agencies would be required to be vaccinated. A judge today struck that for the contractors, at least for the time being, pending further review. And that private employers could offer a testing option. So if employees did not and a lot of times there are a lot of employees that don't accept it for some reason, but yet the employer has to offer testing to those individuals, no matter what sector they're in. This is outside of federal employees, outside of the healthcare. So employers must provide a proportion of vaccinated, and they must report the proportion of vaccinated workers at each site, meaning you have to tell people how many are not vaccinated and vaccinated. Employers must collect actual proof of vaccination. And I've had to do this with where I work, down to what lot number, what was the date, that kind of thing. And they have to prove it. Employers have to collect that information. Testing must be observed, meaning that home tests are not allowed. So I'm sure the occupational medicine facilities will be involved with this. I know I will be. Interestingly enough, tested employees must pay for the test, and a lot of these tests are not cheap, and employees have to pay. And we have to immediately remove COVID cases and those with positive tests, and the employer would have to pay for the time off. But there are exemptions for medical and religious reasons, and that's all extremely very vague, particularly on what those reasons may be, except, for instance, for medical reason would be, having had a severe reaction to another COVID injection, or they had COVID-19, they have a positive test, they should, you should wait about 3 months before you get vaccinated after having COVID. That's an example. So that's a delay. So with that, I wanted to just close, and I'm getting about 10:52, so hopefully we'll get on schedule and be ready for the 11 o'clock lecture with Dr. Ko. So if there's any questions or comments, I'd love to hear. And you can always contact me on my email if you like, as well, if there's any questions, which is Yarborough, CYARBOROUGH at cyhealthassociates.com. Be glad to entertain any questions or comments, because this is not going to go away anytime soon. The after is actually going to be different rather than after. But we will be much more involved for the physicians in occupational medicine. I think it's actually a exciting future in a sad kind of way because it's happened, but it will definitely keep us in the picture for a long, long time. And that I thank you.
Thank you for your presentation, Professor Yarborough. I think it's very late in the night at the United States now.
Yeah.
I want to ask some question about the lung function test. Do you
Yes.
do the lung function test in the worker now?
That's a very, very good question. That's one of what should be on the list, along with how do you do cardiopulmonary resuscitation. But to answer your question about respirators, spirometry, pulmonary functions, we're not doing them right now because of the concern of contaminating the equipment. And also, but if we do them at all, we would take the portable unit at the end of the day, take them outside and have to do the test on the portable unit outside if we had to do it for some reason. So it'd be after people have left the clinic and basically an outside environment to be able to exhale. But we still have the problem with cleaning the equipment afterwards. So currently, we're not where I am. We're not doing any spirometry.
Okay. And would you like to talk about the next meeting of the ACOEM in Utah, Salt Lake?
Yes.
Well, yes.
Yes. Thank you very much for bringing that up. That is going to be exciting in Salt Lake City, Utah. It will. I was, according to the Bill Bruce, who is the executive officer for the ACOEM. It will be in person. I think they'll have a hybrid, but so it'll be partly telemedicine, but it will be in person. And it's going to be in the hotel, the Grand America Hotel, which was a hotel that was, interesting enough, used for the Olympics, when the Olympics were there about 10 years ago, Winter Olympics. So I recommend getting your rooms early. I know it's a long trip, but it's not as hard as getting to the East Coast. So you go to Los Angeles and then into Las Vegas, but to Salt Lake City. So please come. I think you'll have a fascinating time. There'll be a lot on COVID, I can tell you, at the meeting.
Okay.
Thank you for the questions.